Good evening, everyone. Look at all of you. You're all leaders. You all like to make data-driven decisions. And how many people have enough data to do their data-driven decisions? Yeah. It's also important for you to have the people under you, that they have data. And they make data-driven decisions. And you need to inspire them to use data in their decisions, and not enough, huh? It's a big problem in our industry. My co-presenter is widely loved, Marty Hatley. Fortunately, he needs to have a small bit of surgery last minute, so he couldn't be here. Please include him in your prayers. The surgery he needs is very, very delicate. Me? Some of you may know me. I see a couple of faces I recognize from various committees I volunteer in education. We put together, both at the national level at Ashram, where I've been the chair the last year, and in New York. A lot of us volunteer to put together the information that you need to be better leaders. And I encourage you all to take time to also take a spot and be speakers. It's really not very difficult. Usually I'm talking about artificial intelligence, high reliability, or I'm helping other people do the same. Today it's going to be a little more down to earth. We're not going to be talking about the future. We're going to be talking about the problems that are facing us today. This little chart here is just a number of incidents from a safety event reporting system. I am very pleased to be the owner and leader of one of these companies, SafeQual. We believe we have the best software, but I'm not here to talk about this. I'm here to provide take-home knowledge that you can use without my software. So getting to the data, we have 4 years of data up there. The number of events are increasing year over year. If you saw the year before that, there was only a quarter of the number of events. So you might kind of want to think to derive from that harm events are going up. If you're a layman, if you're the leaders in this room that know about this stuff, you know, maybe that's showing an improvement in culture. But that can be confusing if you want to put a number like this in your public areas for meeting the patient safety structural measures, right? It can be a pretty confusing story to tell folks that harm events going up, good thing for our hospital. And all of you, I'm sure, have tools where you can dissect this data and try to look for knowledge from these numbers. And the more and more you dissect these numbers, there's more and more noise. And so it's very hard to get good information, right, just from events. You have to look into the events. And there's been many good presenters over the years, including at this set of sessions that can tell you how to get more data. And sometimes when you can't get more data about the event, maybe you can get some more data as you look to promote your culture, a safety culture across your healthcare system, and measure if people are doing the work so that they can come to the decisions to find root cause and do corrective action. In the patient safety structural measure, they call out some specific sources of data they like to see you use, right? So we have, right, the patient safety structural measure. We've got, 5 domains. In each domain, we have 5 measures. And you could look across 12 of these measures and find data needs that can be satisfied if you can get more information out of your events. Others need to be satisfied from some of these other sources. So the apparent cause analysis tool, everyone here must be familiar with. How many of you actually have used the tool in the last 12 months? There we go. All right. I hope the same number of hands or more can say that people in their healthcare system are using this tool, and it's just your job to inspire them to use it. Is that roughly true? Right? Very good, very good. The best thing about the tool is, you're trying to get some knowledge out of your data. Worst thing about the tool is it's probably not appropriate for some types of events, right? You have RCAA and other tools to use. So this is the tool you use to go quick and fast, right? Find one root cause, not 30. Find a couple of corrective actions. It's a form of structured analysis, and the tool works best if you use it right away after an event, because you can find information, human factors that may be involved in an event, only if you get started right away. And when you're successful, getting these ACAs used right away and getting some good information from it, then you can get the knowledge, or you can get your people to have the knowledge to do the right things, to look for the right actions that they can take in your healthcare system and run it better. There's 12 measures in the patient safety structural measure that can use this data, or the knowledge that the healthcare system is following the processes that you laid out. The best way to use this information is actually to have more of them, to have them on nearly all of your events. Anyone here have them on nearly all your events, either have this or root cause analysis? Ooh, a couple of yeses. All right, that's great. So that's a hard thing to do, though, to get nearly 100% of ACAs, right? And if you're the one doing the ACAs, that's impossible, right? But you're all leaders. What if you can arm people throughout your healthcare system to do the ACAs instead of you? Right? Larry, right? There's challenges in getting that done, right? People won't do it as well as you do, right? No? A lot of agreement there. Well, I'm in software, right? So you can give software tools to people. You can give them pamphlets. You can give them all sorts of things. You can give them training. And I really encourage that you find ways to get them to do it. Because when ACAs are decentralized, when they're done by the people that are actually in the care settings, you can let them bang their head against the wall trying to get the information to finish the ACA instead of you banging your head against the wall, getting all bruised up, right? So, real simple. Now, to use it for the PSSM, there's a couple of enhancements you can apply. And that's really what I'm going to talk about for the rest of this presentation, right? Certainly, when ACAs are used in a decentralized manner, you increase the chances that root causes are found because you start the ACA sooner. People can look at the human factors. They can make decisions better about the root cause, and they can put corrective action into motion. And this is really good. When you do your ACAs and your RCAs all in one central place and you fall behind in getting them done, as I've experienced for a few hospitals, you might pull off 20 or 30 really good corrective actions a year. But when you decentralize them, you can pull off hundreds and hundreds of corrective actions. The things you can do to make them more effective, in addition to decentralizing them, in addition to training an army of 100 people looking to support your patient safety processes and getting those root causes and those corrective actions and cycle time, making things faster and faster. Am I talking too fast? Okay. There's some other things you can do. So first of all, you can start to have, either through AI or through having the people do it, you can get the harm score assigned very quickly and decide whether this is going to go to an RCAA. But if you do your ACAs well, let that always be the starting point, right? If you have some good tools in place, right, get your IT department to make sure you're in a position to have all the information from the ACA kept in one spot, no matter the care setting, that it's all can be compiled into the information you need to do some of the things that are required of PSSM. It's really not so hard to do. So now, as leaders, instead of doing the ACAs yourself, make sure you set up in your organization that when the ACA is done and the reviews are completed, they come to you for a quality check because you're the only ones that can check the quality and go back and say, hey, Larry could say to Dan, like, hey, Dan, I've seen this root cause before. I've seen this correction action before. Hey, man, can you do something a little more aggressive, right? That has to come from you. So now you're the orchestrator of the chorus, of the band, of the musicians. As a leader, that's the position you want to be in. I know all of us as leaders, sometimes we have to clean the toilet or clean the blood off the floor, okay? But the majority of your time, right, can be very effectively used if you outsource this to other people and believe that maybe they won't do it as good as you are, but a lot more corrective action is going to happen. The most important reason to do this is PSSM, the data you need from this, can only happen if you get most of your events to get an ACA through, so you're consistently getting something from this particular source of data. Did I capture? Yeah, I got most of this. I know we all know you're supposed to use slides and have very few words. I tried to load these up a bit so you can download them and have some really good takeaway knowledge. You're always welcome to call me and give me questions, but it's my goal as an educator here that you have takeaway knowledge. So that's why I've committed this terrible, terrible sin on patient safety structural measure. All right, so let me make my point in domain one. Domain one, actually you got 5 different measures, all of which the ACAs can help with. Do I have to prove my point, or are you all going to kind of agree with me? All right, cool. So in the patient safety structural measure, I mean, what they're trying to do, right, they're trying to take all the best practices they ever heard of and raise it up to a standard. Somebody on my committee said, hey, this is unfair. They're trying to boil the ocean. Fair or unfair? They're taking all these best practices and they're making it into a standard. And they're compelling you to do a gap analysis between now their vision of patient safety excellence, which they said comes from all the consultants in this fine organization. Do a gap analysis between that and where you are, and then turn in your answers as yeses and nos. And they have a scoring system that they mention in there. Every domain can get 1 point. 5 domains, potentially get 5 points. So just so we're clear here, on domain 1, and this is the same for any domain, if there's 5 yeses and nos, and you're doing 80% of the work here, what score do you get for domain 1? Yeah. What if 80% of the units in your hospital are doing all of them? What's your score? 0, yeah. What if all but 1 unit is doing? It's still 0, yeah. And that repeats again for every one of these domains. So, I don't like to kill birds, but, with 1 stone, you can hit 12 patient safety structural measures. What's not to like? Well, what is to like is if you can use PSSM, if you can use the threat of a 0 score to go back to people and inspire them, right? Because you don't want to say, hey, boss, we're going to get a 0 next year. And you can inspire the people on the front line that we want to score well. Maybe you can leverage PSSM in your favor. Get some more cooperation. And you want to make sure that cooperation isn't temporary, right? So that's when the data can come in, right? The data can come in a second time for you as leaders. I think the people at CMS were thinking this through in that way also. So let's talk about some data you can use from your safety event reporting system with the help of your IT team, right? Or vendors. This particular graph, it's green and red. So if you have some workflow behind your ACAs, you can start to record data without people having to type them in some cases. For example, you can record when did they start their ACA, when did they finish the review. In a good workflow, after the review is completed, it comes to you and you can close out the ACA. So you can have additional measures, not to use the word, measurements, right, of what's going on with your ACA. You can also say, are you getting close to the 100% that you need to make this a usable tool, right? So look to get those kind of changes implemented over the next year or 2 years so you can get this information. In this case, we've got green is the review is completed in 14 days. Red is that it was not. If you're in the blue, the review wasn't done at the time the graph was created. So this is really pretty typical, right? You see events go up and down, this is quarterly. So, all right, so that's some information you can use as leaders, right? Well, inside the PSSM, one of the things they want you to do is be able to tell them that you have enough resources doing patient safety. How many people have enough resources in their hospital? Not a single hand went up? Okay. I've been privileged to meet some hospitals that did have enough resources. And I hope that changes for all of you. The bottom graph here is labor investment. So, with a little software magic, you can actually measure how much effort's being put into the various processes you have, ACAs, PDSAs, and so forth, right? We're going to just focus on ACAs. This is the labor investment, roughly how much time and hours has been put into this. Now, you don't have to measure people's time. You can put estimated points, so to say, against the different activities that go into an ACA. And this blue graph here shows how much investment's being made. Now, I deliberately put them above each other. So we're looking quarterly now. And again, the top numbers is 14 days. So we have, I think, a pretty well-resourced hospital because as the number of events go up, in general, the amount of investment's going up, okay? If they didn't have enough resources, maybe what would happen is you'd start to hit like a maximum, right? You'd see all those blue things like suddenly go boom, 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 can't get above some number. The other thing you can see from this graph, right, is the area in red, the number of reviews not completed in 14 days, that actually can be correlated to the height of those blue bars. And you can see this a little bit more in another diagram I'm going to show. And you get enough of this data, and you can find where the equilibrium is, right? You can see here, you get not enough labor investment going in, and what happens is you fall behind on the reviews. You got your red bar gets a little bit bigger, right? And here you can see an excellent response. So you're looking to catch up, and the red bar goes down, okay? Irrespective of how many events they have, this organization, or this portion of the organization, is responding well to doing this. Wouldn't you like to work for these guys? This is really cool. This isn't made up data. This is real stuff. This is really cool. I'm really proud of this hospital system here. And we have that equilibrium. We may be able to use that equilibrium as a goal in PSSM. Maybe. I haven't had anyone go do this yet, but I bet that's a really good idea. Anyone want to submit their resumes and go work for them? I know they have an opening. All right. So if there's a correlation between the top and the bottom one, what if we could use that to be predictive? What if instead of waiting until after the fact, we could predict we're going to be in trouble? Don't you anyone have kids? You watch their homework? Yeah. All right. My wife is Asian. She's all over my daughter to get her homework done. It's very predictive of her doing well on her. Yes, I'm looking at you. It's very predictive of the score. So what if you could use this information that your kids are doing your homework, that your units in your hospital are doing the homework, and you can predict how they're going to do the work that needs to be done? And what if you could see that they're falling behind without waiting for the final exam? Well, you also could do that with your safety event reporting system. So I'll approve that here. Now this is going to be a little quirky here because I'm using reviews in 14 days and I'm measuring things weekly, right? So I'm measuring things more often than I'm trying to get ahead of finding out how people are going to do. So back to my measurement, right? Red is you're falling behind in doing your reviews. What's the negative of falling behind in a review? Well, you might miss out on human factors and other things because people can't really recall, okay? Yeah. And I could have done also another graph that shows, did they start the ACA within 24 hours, right? That's another, I could have put that color up too. I don't know, that might have been better. But anyhow, I got this one. And you'll see, this is real data, by the way. Look, failing scores. Okay, we got blue here. That review never got done, by the way. That's unfortunate. But again, it's still really good that this healthcare system, for the most part, they're on top of stuff. But hey, man, we got 4th of July right in here. So labor investment went down. And predictably, we got a little bit of red that follows, right? I mean, they were already in the red before they got the 4th of July. Now they're really in the red, and they actually have a couple of events that never got reviewed. And then look at this response, okay? They put in a ton of labor investment. And the very following, I said this is predictive. After seeing this, you can predict that there'll be no red here. And that's exactly what happened, right? We're completely in the green for 2 weeks. Oh, but the labor investment fell off again. Now we're in the red again. Right? This is predictive. So this is just one of the things you can do with ACAs. Isn't it amazing that you can use data this way? I mean, I got so excited when we were putting this together last year. This is just awesome. I'm glad to be able to share this today. So moving on. Look, there's lots of other things you can get from your ACAs. Just imagine now that if you try to get it from all of them, you now have the data, your people have the data to do better things with these events, and you have the data to understand as leaders, are you being inspiring enough across your organization? And you're satisfying some of the needs of the patient safety structural measure, which, I mean, that's what they want, right? They want you all to be better leaders, and now they're giving you something you can go to maybe your board of directors and say, hey, we need some more resources. It's measurable. That was domain 1. Domain 2 gets into a couple of other things. Are you serving all your populations? Are you doing just culture? Hey, what if you integrated that into your ACAs? Here's an example of a health equity form, right? So if your army of 100 or so people doing reviews, remember again, this is part-time for them, right? They might only do this a few hours a week. They have this extra form there that can be triggered to come up, and they can collect this information and work on it. This is an example of information you're not going to have on every event, right? But you are going to be able to use it to satisfy the PSSM. And maybe you'll even design a better form than this, or maybe this is the best form in the world. I won't swear one way or the other, but you now integrate it into your ACA, satisfying another one of the PSSMs, if you're training your army of reviewers to do this. You know, you can do the same thing with patient safety culture, right? You can have that algorithm worked on every single ACA. All our clients do it for, try not to talk about my product, but forgive me. You know, I've seen hospital systems do the Just Culture algorithm on every ACA, and that's wild. It's not just because, you know, you can use the answers. It's that the people doing the review, you've decentralized your ACA, they're doing the review, instead of it being like a reminder on the wall, it's right there in their face, they're answering the questions, and any you know, yes, no set of questions can be turned into, hey, this looks like a systemic issue versus something else, and you get that person thinking about that, and you get that person asking questions in their care setting, engaged with their people, and the nurses are like, yes, they taught us about Just Culture, and they're practicing it, right? And if they don't practice it, maybe we can measure that too, and you know, have a conversation with them. Arm you as leaders to have that conversation. Domain 3, you know, actually here's a Just Culture dashboard generated from ACAs, right? It's right there. It's all collectible. You can, as leaders, and sometimes you're the local expert on just culture, you can watch for changes over this, certainly, but that's kind of like, I hate watching dashboards. I'm sure many of you would hate the same thing, but I teach artificial intelligence also, and I'm going to divert to artificial intelligence here for a second. There's not enough information in your events for artificial intelligence to save you, and it certainly isn't going to help you do the patient safety structural measure. But artificial intelligence can be engaged in a couple of ways. And it certainly helps. The more data you get from your events, the more it can help. I like to think of it as it's going to be good for being a co-pilot, because we've already tested this. It can be good at co-pilot to help the reviewers stay on track with just culture, help them do their ACAs. I think also, as time evolves, we can have AI drive the questions that are asked of the reporter, over time recognize what their fears are, maybe as long as we're willing as data people to say, I don't need every question answered on every review. I just need the right questions asked. I need the minimum number of questions asked. And I'm willing to leave it to the reviewer to get the rest of the information. AI can also help there. But you still need all these ACAs. It sets you a very good foundation to use artificial intelligence later. And one of the ways you can use artificial intelligence is to watch the dashboards. How is it changing, right? So you can use, that there's not enough labor investment happening, okay? You can go have a conversation with that care unit. You can do, I volunteer with Ashram. We have a great course on finding or diagnosing problems with just culture in an outpatient setting. That kind of material I'm sure is available from IHI too. You go apply it, right? Then you tell your AI engine, I've set new goals for this care setting, and let it watch the Just Culture dashboard down to the care setting level. Let it watch the labor investment, and let it come back to you not only if that care setting is failing, but also to come back to you and say, hey, they're getting better, right? So you can be, as leaders, going and rewarding those care settings and giving them a pat on the back, as well as there's enough information here to realize that maybe key people left a care setting and they haven't been replaced, right? Maybe a labor investment went down, or our reviews are getting late because a key person is on maternity or left the organization. They haven't been replaced. If I back up all the way to those slides, you can find that out just from the graphs, or in the future, you can have the AI call that out for you. And within 1 week, your kid's not doing the homework, and you can respond. Maybe even have the AI respond with an email saying, hey, this is Larry's assistant. See, you're falling behind on this key important thing to us. Can I offer some more training? Because I see you probably have to assign this to somebody else now that Karen is no longer with us, or Mark has moved on, right? That kind of being on top of things, that's what I think we can use AI with in combination with this. Domain 4. This is a scary one. Making your patient safety metrics public. Oh, look at that, yes, yeah. That's scary, right? So what do you want to put in your public areas? Do you want to put in the number of events, right? Do you want A to go out and be on the walls or on the computer monitors in your public areas? Or maybe you want B, right? B is easy to understand. We're putting time in because we care about our patients. B also could be inspiring, right? Imagine the nurses and that you rely on, the providers, they're going to do the ACAs. So they can't do an ACA unless you report an event, right? More events get reported. That already happens, by the way. When you decentralize ACAs, you double or triple the reported events, or quadruple. Now you can set goals and put those goals in the public areas, and the nurses see that, and the providers see that, and they're like, oh shit, we're below that number, okay? it's not just that. It could be every time someone's doing the work, they're going to be thinking, hey, that blue bar goes up a little bit. It's a bit more motivating. Because sometimes you need something. You need that measurement. If it's important to you, let's show them that measurement. So do you want A or do you want B in your waiting rooms? Okay? I'm sure you're all bright people. You can come up with other ways to do it. I thought of 3 or 4 ways even before I was putting this together. I know another thing I would put in my waiting room, or at least put into all my units and let them see is, what is the distribution of work? Okay, what is that labor investment? Is it falling all on one person, or is it distributed across a bunch of people? Maybe even put in numbers like, what percentage of my nurses are reporting a near miss in any given quarter? Is it close to 100% or 50%? You can do these things with your ACAs. I encourage you to do that. So I think I covered this. Patient and family engagement, man, oof. I know a few risk managers that are scared to death over this one. You can, this one, I can't say that the ACAs are going to be helpful except in D. In D, it sure helps if you can put like a QR code or some other way to get the patients and their families to also report events. You want to make sure, I guess this is obvious, you don't want to give them the same question set, right? You want something a lot simpler and get that in. And even if that you seem to think that might be incompatible with how you run your other safety events, at least still run it through your ACAs, okay? And combine that data, because that should also count towards that investment in time and the things you want to encourage to be happening across your system. And I hope I was helpful. You all had a lot of takeaway knowledge from this, because hey, as educators, that's what we want, right? But as leaders, I'm a leader. You're a leader. I really want to see your success. Please download this and put it in action. Yeah.
Could you do the patient safety event reporting through the patient complaint or grievance portal so that the patient doesn't have to figure out whether it was actually a safety event?
Yeah, I would encourage that. The same portal captures all of this. Yeah. I don't know if, I would think, we haven't done this yet, but I'm going to certainly encourage my software team to run the complaints the same way. It'd just be different question sets, something simpler for the reviewer to do so that we can total up the information.
Can we take the concept of observability that we do? Can we take the concept of observability that we do? Am I not loud? I've never been such a quiet gal.
They're recording this.
Oh, I see. Can we take the concept of observability in AI governance to kind of create a mesh network of observability and charting and create a CDS tool that says, hey, here's something you didn't fill out that will be needed in a PSSM assessment later on down the line, and we start prompting everyone engaged in a patient interaction so that we have iteration across the MDs, RNs. Can we kind of create that sort of a support system because we know what the criteria is and kind of engineer it backwards?
Well, you know I'm going to say yes.
Yeah.
Great
but
idea.
Do you have anything in the works?
Jeff, do we have something in the works like that?
Yeah, so what we want to use, there's 2 methods of going about that, right? One, I'm fine with it, yeah. One is the decision trees. So you can build decision trees that are triggered off of required fields, and you can change them by care setting or location. That's one way. The other way is on the reverse engineering side is don't focus on what we know, focus on what we don't know. So the process of elimination of saying, here's all the things we have, but you're highlighting all the things we don't have, and then we need to go run down that information, and it's triggering you to do that. So that's probably what you're really asking. Yeah. So yes.
More good questions? That's a great question. Any dumb questions?
And so, just a little background too. So if you guys don't have questions down, you want to ask questions later, and you think of things, please reach out. So Dan, his background was solving these complex problems for like AT&T and Verizon. Mm-hmm. So it started out servicing a that's why Dan got involved. So Dan comes from a good place, a good heart, he really just wants to help the industry. So if you have questions on ECAs or anything else, our information is back there, we'll answer it, we'll give it to you. The rest of the healthcare industry, it has had this level of scrutiny that PSSM has, but what it's going to cause is in competitive markets, that public scoring and that information is going to cause you to have to become intuitive and be creative to separate yourself from the pile. So that's really what you got to start thinking about.
Did the reporting period start this January 1st?
Yeah, so you're gonna have to in 26 you'll have the public scoring, and then that information will be triggered in 27 to affect Medicare, your Medicare reimbursement, and again that's gonna change dramatically because what's gonna happen. I came from all the post-acute side, so I saw this in skilled nursing facilities, home health, hospice, long-term care. I saw this. I built EMRs doing that, and what they do is they'll get the data. They have no idea where they're gonna go with it. Once they get the data, then they're going to find out where the bad acting is happening, and then that's where they're going to punish that behavior.
So the first penalties are in 26?
Well,
7.
27.
I just have something to add to that. If you put aside penalties for a second, because they're not clear about penalties, and I guess there's also a little bit of hint of a carrot in there too. What is not clear is, can you count what you do in August towards answering at the end of what you've done for 2025? They're not clear about that, but it's got to be, the answer's got to be yes. If you're doing stuff now to make things better, and in 2026 you're answering about 2025, probably if you did something in August or November, you could still fudge and say yes. And then that's going to drive in fall of 2026, when they're publishing your score of not 0, that can be driven off of your answers for the end of 2025.
Yeah, but if you want to win, in this area, the key to it is what Dan was talking about with the decentralized ACAs. What you really want to focus on is the communication of everybody working together. Because right now, unfortunately, it's in silos. So what they're really trying to get after is there open threads of communication where everybody has a centralized place to be able to communicate and share information. That's really what they're going to hone us in on.
And there's no credit for improvement. It's just all or nothing per domain?
Correct.
A for effort. If they can give you an A for effort, but they don't do that, right? So you're going to get down to it, and that's the same thing on value-based purchasing models, right? So it's the same concept. Like you can improve dramatically, but you're still going to get less reimbursement on a value-based purchase model because you don't meet the threshold, right?
Yeah. So if you're doing 90% of this really, really well, you don't get 3 stars, 0. But look at the bright side. You have something to go, hey, boss, how about filling all those empty staff roles that you promised? This is the time to do it, and maybe add a couple of more people. Enough said. Questions? Thank you. You've been a fabulous audience.